Have you ever not been sleep deprived, but suddenly found it impossible each day to stay fully alert and awake during critical times when you really need to perform? Did you know that a sleep disorder called narcolepsy affects an estimated 1 in every 2,000 people in the United States? That's about 200,000 Americans and approximately 3 million people worldwide, and it is estimated that only about half of all people with narcolepsy have actually been diagnosed. Have you ever found it difficult to get your brain to wake up from sleep, even after more than 10 hours of rest? Even after you have slept 10 hours a day, every day for the past month? Well, that is what happens to people who suffer from a sleep disorder called idiopathic hypersomnia, which affects about 1 person out of every 10,000 in the United States. Today, and over the next few segments of Hope in the Pipeline, I am going to discuss these 2 sleep disorders, also known as hypersomnolence disorders, to help you understand what symptoms they have in common, but most importantly, to understand how they are unique. I will talk about what causes them, how they are diagnosed, what current treatments are available, and as always on Hope in the Pipeline, I will talk about what clinical trials are going on to help develop new and better treatment options. Narcolepsy is unfortunately usually a lifelong disease of the central nervous system, caused by a lack of a neuropeptide called hypocretin or orexin. Orexin is normally produced in the lateral portion of an area in the center of our brain called the hypothalamus. This neuropeptide helps regulate our daily sleep-wake pattern by promoting and, in particular, stabilizing wakefulness. Hypocretin or orexin also is a strong regulator of our motivated behaviors, such as appetite and sexual desire. Exactly why some people have low hypocretin levels and develop narcolepsy isn't always known. Narcolepsy can be related to genetic factors, inflammatory disorders, infections, and brain injuries. Most cases of narcolepsy, particularly type 1, we think are the result of the immune system mistakenly attacking the brain's hypothalamus nerve cells, which produce hypocretin or orexin. The immune system mistakenly thinks the brain cells in that area are an infectious agent to be neutralized, after already having been primed to attack them following an infection by an infectious agent that has a similar outer protein coat. We know that hormonal changes can trigger an abnormal response in our immune system. Narcolepsy often begins during puberty. Other triggers for narcolepsy onset can include sudden severe alterations in the sleep schedule or experiencing a major psychological stress. Further proof of abnormal immune system functioning in narcolepsy comes from the problems with the 2009 H1N1 swine flu virus that caused people to develop narcolepsy. Also, the vaccine for that H1N1 virus, called Pandemrix, which was made by GlaxoSmithKline and approved for use only in Europe, primarily in Finland, also caused some cases of narcolepsy. The primary symptom of narcolepsy is an overwhelming need to sleep suddenly during the daytime that's almost impossible to resist and repeatedly occurs, despite often involuntary daytime naps and even despite getting plenty of sleep at night. The sleepiness attacks can occur at inappropriate times and places without warning, resulting in challenges while at school, work, parenting, and while driving, and contributing to an increased risk of workplace and driving accidents. It is important to note that the irresistible naps in narcolepsy are refreshing and restorative of alertness to the patient, but they are just not as refreshing for nearly as long as they would be in an unaffected person. Narcoleptics can experience what are called microsleeps, which are very brief, just a few seconds long, episodes of sleep brainwaves while awake. So as a result, paradoxically in narcoleptics, nighttime sleep is often very fragmented and of reduced quality. This is in part because the episodes of microsleeps and naps throughout the day contribute to the drive to sleep at night being reduced, and so therefore it's harder to maintain sleep at night. Also, it's harder to maintain sleep at night because narcolepsy features what we call a porous sleep-wake barrier. Remember I said before that narcolepsy is caused by the lack of hypocretin or orexin, a neuropeptide which promotes and stabilizes wakefulness. So in some ways, narcolepsy's daytime sleepiness and nighttime poor sleep can be understood as being the result of a porous barrier between or an unstable switch controlling being asleep and being awake, causing wakefulness to leak into sleep and sleep to leak into wakefulness. In addition to this intrusion of wakefulness brainwaves into sleep, individuals with narcolepsy may experience additional sleep quality disruption due to being at increased risk for suffering from other sleep disorders, such as periodic limb movement disorder or unrecognized sleep apnea. Now, besides the daytime sleepiness, there are 3 other main symptoms of narcolepsy, although not all patients experience every one of these other symptoms. The presence or absence of these other symptoms has led to there being 2 main types of narcolepsy called, you guessed it, type 1 and type 2. About 20% of all narcolepsy cases are considered to be type 1 because they experience something called cataplexy. The majority of narcolepsy cases, about 80%, are considered to be type 2, which does not involve having cataplexy. So, what is cataplexy? Patients with type 1 narcolepsy can experience, while fully awake, episodes of sudden, brief muscle weakness, usually combined with experiencing an emotion of some type. These could be negative emotions such as anger, anxiety, fear, or sadness, but also more commonly, cataplexy happens in response to pleasant emotions such as surprise, joy, and laughter. We've all heard the saying, "She collapsed with laughter." Cataplexy episodes can take a lot of forms, ranging from mild effects such as a few seconds of eyelid drooping, or the facial muscles becoming weak on one side. The head may nod, or speech may be momentarily slurred. A person's hands may drop whatever they're holding. There can also be more dramatic cataplexy effects too, such as loss of muscle tone in the trunk and leg muscles, resulting in a collapse to the ground for a few minutes. There is a questionnaire called the Stanford Cataplexy Scale that is available online if you are interested that covers a ton of possible cataplexy manifestations. Cataplexy episodes can happen as infrequently as a few times a year or as often as a few times a day. And I want to emphasize that these episodes occur while the person is fully awake and conscious and aware. I know of a person that participated in a clinical trial for narcolepsy who reported being a member of our judiciary and reported that while presiding over exciting elements of a criminal trial, that she experienced episodes of cataplexy, and as a result would fall out of her judge's chair, unable to move or talk, but yet fully aware. And then the trial would resume after a few minutes until the cataplexy episode would happen again. The onset of cataplexy episodes usually follows the onset of the excessive daytime sleepiness of narcolepsy by many years. In fact, 50% of patients with narcolepsy don't develop cataplexy until an average of 26 years later. Pretty amazing and kind of scary, but it shows that the immune system causing narcolepsy, the problem, may not ever go away in some people, and it may continue to slowly cause additional damage to brain cells over time. I think this is a good spot for me to end today's podcast and resume next time because I'm about to go into depth into another aspect of narcolepsy. Specifically, I will talk next time about what we know regarding the cause of cataplexy and discuss even more components of narcolepsy. As always, please like, rate, and review my podcast, which helps more people to find it and to learn from the content. If you know someone who you think might benefit from viewing this podcast episode, please share it with them. As always, thanks so much for listening to today's presentation and to the beginning of this series on hypersomnolence disorders on Hope in the Pipeline. We'll see you again next time when we'll continue our series. Until then, stay safe and stay well.